So bone strength is critically relevant here, but the way that we move in the world, our proprioception, our physical literacy, strength, coordination, agility, we can attain those without a high level of load. And all of those are really, really important, both from like a fall prevention perspective, and then also just mitigating some of the effects of a fall that may occur. The physical part of bone health prescription is non-negotiable.
Welcome to Personalized by VitaminLab, the show where we dive deep into the world of personalization in healthcare. I'm your host, Dr. David Duizer. Please remember that the following discussion is for educational purposes only, and is not intended to diagnose or treat any disease. Speak with your healthcare practitioner first before integrating anything that you learned today. Join us as we explore the remarkable stories, breakthroughs, and possibilities that come with the pursuit of personalized healthcare. Welcome back to Personalized by VitaminLab. I'm your host, Dr. David Duizer. Most people don't think about their bones until something breaks. There's no burning sensation, no early warning ache, just a slow, silent loss of bone density that often goes undetected until a fracture forces the issue. By then, the conversation has shifted from prevention to damage control. My guest today wants to move that conversation to much earlier. Dr. Todd Levins has been in practice since 2004, with a career built on the essential role of movement in vital health. That focus has led him in recent years to bone health specifically, and to being a co-founder for Bone Health BC, a company dedicated to helping people understand and act on their bone density long before a fracture forces the issue. Today we get into why the standard testing often misses the full picture, the real differences between DEXA scans and REMS ultrasound, and why bone health protocols can't be one size fits all. There's no single bone protocol that works for everyone, and the right approach depends on your specific numbers, your history, and what your bones actually need. And Dr. Levins walks us through how he builds that personalized path for each patient. Please enjoy our conversation with Dr. Todd Levins. Welcome back to Personalized by VitaminLab. I'm your host, Dr. David Duizer, and today I'm here with Dr. Todd Levins. How you doing today, Todd?
I'm excellent. Thanks for having me.
Oh, no problem. I'm really excited to speak with you. I've known about you for a long time, and then just recently learned about your company and got really excited and working with you guys just a little bit, and actually have had lots of patients go through the process without me even really knowing about you because the word's getting out. So way to go, man.
Yeah, well, I appreciate it. Yeah, it's been, it takes time, but momentum works, right?
For sure. So your company's called Bone Health BC, and you've got significant expertise in osteoporosis management and osteoporosis prevention and the treatment of osteopenia. Can you tell me about how you got into bone health in general? How did your career take this turn?
Yeah, I mean, my practice has always been focused on physical medicine. So I've always been, sport focused, injury focused, and injection therapy has always been a big part of what I do. And from a prolotherapy perspective on anatomy, we think of anatomy as a balance between forces of compression and forces of tension. And my lens on physical health is very much about understanding where that force is being transmitted, how it's being transmitted through the body, and then what can we do from a strength perspective or from an interventional perspective to rectify that, to understand where there are imbalances there. So that framework of thinking about things from forces of tension and compression has always been there. And of course, when we talk about bones, we're really always talking about that muscle bone unit and talking about and thinking about the forces that are applied on those bones in a healthy and in an unhealthy way. So that's my lens was there. And then, like many things, pandemic related disruption, one of the things that brought to light was all these screening programs that we have that fell away.
Right.
And in the health authority that I'm in, the VIHA, Vancouver Island Health Authority, the average wait time for a DEXA is 347 days.
Wow.
And DEXA is not even a screening modality. It's a diagnostic modality. So we have all these screening programs that fell away, and then this awareness that what we do to diagnose this disease state has this really long ramp up time that brought those things together to have an understanding of, well, what can we be doing here to improve this for our patients?
Cool. Very cool. Were you always interested in physical medicine? Like, did you get into naturopathic medicine to do this kind of work?
I've always been interested in physical medicine. You know, I was part of the sports medicine group at I graduated from Toronto, from the Canadian College of Naturopathic Medicine there. Sport has always been a big part of my life. So it was always something that was interesting. I like working with that population. For me, my bias on practice is to stand on a foundation of biochemical understanding, structural understanding, and then build up from that and understand things from a mind-body relationship and otherwise. So that's the foundational aspect of my approach to practice. But as you know, we are naturopathic doctors, and we have a wide breadth of training and a lot of things to pull from. And that's what makes our practices unique from individual to individual. We share commonalities. And for me, that structural and that biochemical, that's the foundation that I stand on, and then I pull from a lot of different areas.
For sure. I just recently, in the last sort of like 3 to 5 years, started seeing more healthy people, more people who are interested in living better and also at the same time kind of like trying to figure out how to live longer.
Yeah.
And so we're like actively doing screening and like proper screening programs and really thinking about what that looks like to live healthier and to live longer. And that's when I started catching all these osteopenia cases and some osteoporosis cases and really having to think about this more deeply. Before that, it was just, I wasn't really my world, right? Randomly people would come in and say, oh yeah, I've got osteoporosis, I'm being treated conventionally. And, but now with the whole longevity movement that's present, I think that more people are becoming in tune with kind of the work that you're doing. I know that DEXA scans in Vancouver have become incredibly popular.
Yes.
And people are going to do what they call private screening all the time. And so I think that there's a huge spot for you. So that's been kind of my journey, is just like landing here because of like longevity medicine.
Well, and truthfully, and somewhat embarrassingly, my conception and my approach to osteoporosis was quite passive.
Same.
I accepted it as an inevitable consequence of aging, that it was silent. I did not appreciate the prevalence. I did not appreciate the severity. I did not appreciate the morbidity. I didn't appreciate the impact on public health, on societal health, on individual health. And it is so, I think it's always useful for us as clinicians and as just as humans to, when we realize a bias, implicit or explicit, to confront it, to educate yourself around that, and then to do better. And when that also presents an opportunity to provide improved care, to provide through the lens that you're discussing, like that concept of longevity, that concept of kind of backcasting, like what do you want your 70s, your 80s to look like? Where are you at now? What can we do from this point forward to help to manifest what it is that vision is? And then, we're physicians and we're also business people. And that recognition that, well, there's a whole host of people out there who are being underserved, undercared for, underassessed, and who are laboring under that same misconception that I had, that this is an inevitable consequence of aging. Well, then there are things to explore there.
Yeah, right. So tell me about some of the things that you learned. Like maybe start with prevalence and morbidity, and then move to like actual action. Like, so what did you learn over the course of this undertaking that you've gone through?
Well, I mean, osteoporosis is underdiagnosed at a rate of about 50%, probably even more. There's at least 2.5 million Canadians living with diagnosed with osteoporosis, so we can safely double that number.
Right.
It's massively expensive to the Canadian healthcare system. Fractures alone are about $5 billion.
Goodness.
Over 20% of people who experience a hip fracture are going to die within a year. That number is higher for men. 33% of men are going to die within a year of that. 22% of women are going to die. Goodness. 1 in 3 hip fracture patients are going to refracture within the course of a single year. And over 50% are going to refracture within 5 years. There there's more hospital days accounted for with hip fracture than there are for stroke, diabetes, or heart attack. More men are going to get osteoporosis than men are going to get prostate cancer. Osteoporosis accounts for more prevalence of diagnosis for women than the combined of breast, ovarian, and uterine cancer. So we have this like massively prevalent, massively impactful disease state at an individual level, at a public health level, at a societal level, that we still have this conception of as well. It's just an inevitable consequence of aging,
Yeah.
and it is not. And then we have a system in BC healthcare system that's powered to diagnose osteoporosis when it is firmly entrenched.
Right.
So, if a patient does not have a risk factor for osteoporosis, and those risk factors include, a parent with a hip fracture, history of 3 months or more of glucocorticoid use, rheumatoid arthritis, more than 3 units of alcohol a day. There's a number of those factors. But if a patient doesn't have those, then you can only access a DEXA scan at age 70. And it's a big undertaking to then claw back bone health at age 70. And avoiding frailty is on the top of the list of so many patients. And we cannot help patients avoid frailty if we're only assessing these changes when they're in their seventh and eighth decade of life.
VitaminLab revolutionizes personalized supplements, empowering health practitioners to create tailored supplement formulations that address each patient's unique needs. Bring personalized health to your practice and choose from over 200 professional-grade ingredients to create vitamin formulas that improve patient adherence and result in tangible outcomes. All ingredients are sourced from the world's most trusted suppliers, and VitaminLab provides hands-on support to help you formulate and launch personalization to your patients. Say hello to a new era of personalized supplement solutions. Go to getvitaminlab.com/personalized to save $100 off your first formula.
Completely. Well, that's an excellent review, by the way, with so much value just in that little review alone. So thank you for that. For people who are watching, both patients and clinicians alike, if you could give us a quick overview of what a DEXA scan is and what it's measuring, and then maybe contrast it with ultrasound screening.
Yeah, of course. Any imaging of the body, we are essentially directing energy or matter at the system, and then some type of computational processing is making sense of that. So with DEXA, we're using ionizing radiation that's directed at the region of interest. So for a DEXA scan, those are the lumbar spine and the right or left femoral neck. And that ionizing radiation is, that's strong enough to be stripping away electrons of atoms of tissue that's in the path of those beams. So it's relatively low level, but ionizing radiation is ionizing radiation. It does create some degree of tissue damage. What DEXA actually measures is bone mineral density. And it's important to keep in mind, whatever we're measuring, what is the unit that's being measured? Because it gives us information about what it is that we're measuring. And the unit of measurement of bone mineral density is grams over centimeters squared. So that is the measure of density. But what's really important to keep in mind there is that it is centimeters squared. So that is a two-dimensional measurement. Bones aren't two-dimensional. Bones are volumetric, bones are three-dimensional. So we have this diagnostic tool that gives us information, which is clinically useful, which is the standard, and it's giving us a two-dimensional measurement. And that is, by the very definition and anybody's awareness of what a bone is, we can appreciate and understand that is a very small part of what is relevant to bone. So DEXA is the standard. It is what is used for the diagnosis of osteoporosis, and it is measuring the cortical bone, that outer layer, which is somewhat analogous to enamel on the teeth. So it's dense, it's hard, it's structurally sound, and it is just that outer layer. So DEXA does not give us information about the structural component of the bone, what we would call the trabecular bone. Whereas And if I can lead into this other method of assessment, which is REMS. So REMS is radiofrequency echographic multispectrometry, which is a mouthful. But essentially what that is saying is it is an ultrasound-based modality to assess both bone mineral density, so that cortical bone, and it provides information about that trabecular bone, which is the structural component of the bone. So we get information about density and strength and structure. And that's much more clinically meaningful to having an understanding of what is going on with an individual's bones.
Wow. So you'd say it's more clinically relevant for clinicians?
Well, yeah, I mean, we're involved in the assessment of patients' bone health, and the REMS is the modality that we use. And REMS is Health Canada, FDA, WHO approved, and the research backs up the validity and the reliability and the consistency of it. So, we've made a conscious decision at Bone Health BC to use this modality, this assessment method, to get information about patients' bones in order to be able to help support the plan and really have an understanding of what truly is going on with the entirety of the bone rather than just that cortical bone.
Tell me about the accuracy and validity, maybe compared to DEXA for osteoporosis, because it's not the diagnostic tool. Would you say that it's strictly a screening tool from your perspective? Like, what is it approved for?
Yeah, so that is a very important distinction. REMS is not diagnostic. It is an assessment, and it is not diagnostic because it does not get reviewed by radiology. Sure. REMS is AI backed, so there is a database that those patients, that scan results are compared against, so that is evidence informed. But it is a very important distinction that it is not diagnostic, it's an assessment. It is a screening tool. Pardon me, you had a second part of that question.
And the accuracy and validity.
Oh yeah, okay, so the accuracy and validity. So the R value of REMS in comparison to DEXA, so R value is a level of concordance, with 1 being perfect concordance, so absolute agreement. The R value of REMS to DEXA is 0.92. So we have this high level of concordance between those two data sets. And it is important to keep in mind that while DEXA is the standard, it isn't a gold standard. It doesn't hit those marks. It is what we use. It is internationally accepted, but it is not a great tool. Mm-hmm. So comparing it against the standard is very important. And we see that with that high R value that it stacks up well to DEXA. But when we look at comparatives between the two, so the least significant change of DEXA can be upwards of 3%, which doesn't necessarily seem like a lot, but if you compare that against the effect of a lot of the therapies, so many of the anti-resorptive medications that we use have an effect of about 3%. So you have this diagnostic tool that has a least significant change of up to 3%. You have a drug therapy that has a net effect of about 3%. Well, we're using a tool that has a level of essentially error to measure an effect of a drug that has an equal amount of positive gain. The least significant change of DEXA is 0.88 to 1%. So there's a relative improvement there.
Mm-hmm. Of REMS, you mean? Of REMS?
Of REMS, yeah, exactly. DEXA is prone to a number of different artifactual errors. So it's prone to positional errors with the patient. It's prone to errors if there's the presence of osteoarthritis, any kind of surgical hardware, surgical cement. And then there's calibration errors. So those machines need to be calibrated with frequency. Patients need to be, if you're compared over time, that individual needs to be tested or assessed on the same machine, optimally from the same operator, which of course doesn't happen. Mm-hmm. So right off the bat, we have these errors that DEXA is prone to. So that inter-operator error that exists with DEXA does not exist with REMS. The intra-operator error that exists in both of them is much less significant in REMS than it is in DEXA. So
really,
the intra-operator error in Dex is 2% and REMS is 0.38%. So
No way.
we have all these determinants that show from a high level evidence basis that REMS has some displayed superiority in accuracy and validity and consistency.
Yeah, incredible. So who's the patient getting the referral for REMS then? Who's the ideal person to use this technology for assessment?
Well, back to that model of screening, from an evidence-informed perspective, we suggest that any male or female over the age of 45, a screen for bone health is indicated. The idea of that is that, we want to disrupt this notion that osteoporosis is a non-modifiable, inevitable consequence of aging. The mechanisms, the physiology, and the data don't bear that out. If we can get ahead of this and understand what someone's baseline is, then we can support that patient in a meaningful way to maintain or to improve on their bone health. And the peak bone mass occurs at age 30, and there's, for the vast majority of people, there's going to be some gradual loss over that sort of falls off a bit of a cliff with menopause, and there's some evidence to show that even with in the early stages of perimenopause, then that's going to have a meaningful impact on bone health. So if we're assessing that baseline at approximately that age 45, then we have data over time. And of course, we understand this from physicians who are preventative focused, that trend over time in any of these, any variables that we're looking at is meaningful. And if we can correlate those changes with other changes in an individual's health, then we have an idea of how those health events are impacting the system as a whole. And then a means and a method to get restoration in place.
Mm-hmm. Excellent. So it's a screening tool starting at 45, both male and female. Lots of things that we can be doing to support these patients, which we'll get into. But the next steps for a clinician, say for example, if REMS shows osteopenia or osteoporosis, or you have concern, and then the diagnostic criteria would suggest this is okay, send them for a DEXA at that point. Is that how you approach it? I mean, is there really a need? I guess to interact with the conventional system, you would need to take that next step, I assume.
Yeah. I mean, the DEXA is the standard. It is where the diagnosis comes from. So if a diagnosis is required,
right.
In other words, if we need an indication to initiate a drug therapy, we need that diagnosis.
Sure.
And that's where there's going to be an escalation. We're going to write a consult note to a primary care provider or someone within the conventional medical system to try and expedite that with the presence of those risk factors. From a screening perspective, if we have an understanding that the validity and the reliability and the consistency of REMS is supportive of understanding that what we are trying to assess with this modality is a true reflection of what's actually there, then we can implement changes from a lifestyle perspective, from a supplement perspective, from a movement perspective, from a hormone therapy perspective, whatever is indicated, and then track that over time.
Yeah.
With REMS. DEXA is sensitized to check clinically meaningful change at 24 months. REMS detects some statistically meaningful change at 6 to 8 months.
Wow.
So we have, this is another benefit of REMS, particularly when we're talking about screening and REMS is non-radiation. Then we have a tool that is sensitized to detect change at a smaller interval. We're not exposing the patient to radiation, and then we can serially monitor those people over time to understand what's changing.
Yeah, it makes total sense. What's the patient experience like? So what happens after the scan? What kind of report do they get? What's included within the report?
Yeah, great question. So the scan itself is about 15 minutes. So those scans are conducted by sonographers. A probe is placed over the abdomen to detect the L1 to L4, and then placed over the hip to acquire data on the femoral neck. So that's about 15 minutes, and then almost immediately, within about a minute, the machine, the REMS machine, generates a report. And that report specifies the patient's, on page 1 is the bone mineral density and then T-score and Z-score. So that would look almost exactly like a DEXA report. And that's intentional because it's a comparator. And then the second page of that report is a report on the trabecular bone, which is called the fragility score. So the fragility score is a value out of 100. The higher that number is, then the weaker that individual's bone strength or trabecular bone is. And that fragility score is generated when that machine is comparing an individual's ultrasound. It's essentially looking at slices of that bone through ultrasound and then comparing those slices against a database of 2,000 people that went through a 5-year longitudinal prospective study that were regularly getting REMS, regularly getting DEXA, and tracked for pathological fractures, for fragility fractures. So when that individual who's getting scanned, those ultrasound slices are compared against that database, the more of those slices that are similar to those that experienced fragility fracture, then the higher that fragility score is.
Genius.
So the lower that number is, the stronger the bone, the higher that number is, then the weaker that bone is. Then the third page of that REMS report provides a matrix score. So that combines the patient's bone mineral density T-score and that fragility score, and then gives a predictive value of what their percentage likelihood of fracture over the ensuing 5 years is. And that's a high level evidence-based number as well. So we get discrete bone mineral density, we get discrete trabecular bone strength, the fragility score, and then those get matrixed together, and that provides a 5-year predictive risk of fracture at the site that's being assessed. So the one specific to the lumbar spine and then specific to the femoral neck of the femur.
Genius. I love it. That's so awesome.
It's powerful. It's meaningful data, and it provides a good window on much more than just the density alone.
Yeah, completely. Is there any prep required? Like, what do patients have to do before?
No, there is some. We prefer patients not to do any strenuous exercise before, and the reason for that is a little bit of edema in the muscles can scatter those ultrasound waves a little bit. And then we have patients fast for 4 hours before, and that's really just because gas in the intestines will essentially will obscure those ultrasound waves to get into the region of interest. So we can often, everybody's got gas in their intestines, and just a little bit of movement can often just move that so that opens up a window. But those are the two things that we recommend that patients do in prep of the exam.
Yeah, for sure. Okay. I love it. We're going to get into programming in just a second. And we already kind of covered about risk factors. You kind of got through some of the key risk factors that might help a clinician decide if this is the right tool for them or the right person in front of them to go for. But are there any situations, because I know you've done a ton of screening of people over 45 who maybe don't have risk factors. Are there cases where you have been like, I just wanted them to screen and here's what we found and it surprised you completely?
Yeah, well, I think it's important. One thing I didn't mention is the genetic component of this. And 60 to 80% of osteoporosis is genetic. Then when we pass that through the lens of understanding that osteoporosis is significantly underdiagnosed, that becomes a little bit more challenging to understand the genetics of that. And that is largely why one of the risk factors for indication for DEXA is, do you have a parent that has had a fractured hip? And that fractured hip in a parent stands essentially as a proxy for a diagnosis of osteoporosis, because there's a recognition that, so many cases of osteoporosis are undiagnosed. So that, from a screening perspective, and understanding that, again, that this is a modifiable course, and it's not non-modifiable, just as genetics are modifiable to a certain extent. So it is important for me as a clinician to have an understanding of the patient in front of me. Have they have a parent that has either been diagnosed with osteoporosis or has a parent had a fractured hip. That alone, keeping in mind that 60 to 80% of osteoporosis is genetic in origin, that alone is an indication.
Yeah.
I think, I've had a couple cases of patients who either had active eating disorders as adolescents and or, because unfortunately these often go hand in hand, had elite high level athletics.
Yeah.
And this is, there is a gender bias here. This is more common in young females than it is, so what used to be called a female triad that is now a REDS, relative energy deficiency syndrome. That appears to have a lifelong impact on bone health. And, when we think of bones as this nutrient bank, and we understand that these growing adolescents, either from an active eating disorder or from an energy deficiency state, are, from a physiologic perspective, are pulling from what is available for physiologic needs, then we can have an understanding and appreciation that it's possible to have these lifelong impacts on bone health. And unfortunately, we do see that. There is in certain parts of the academic and clinical bone health world, osteoporosis is often called a disease of childhood. And that has a lot to do with, we're building up our reserves. We're building up our potential in childhood. So that's not just from an energy availability perspective, keeping in mind that bones need to bend, that those positive forces of tension on compression. Sedentary childhood is associated with low peak bone mass. And so having an understanding of what childhood health is like is important in terms of understanding what the trajectory of bone health over a lifetime might be.
Wow, great example. Yeah, I didn't think you were going to go there. That's awesome to hear, as I try and raise 3 kids and feed them every day. It's a tricky spot to be because there's so much responsibility involved, and you got to do a great job. It's actually, quite empowering, I think to hear that, because it really enforces the things that my wife and I have been focused on for them.
Yeah.
You know what I mean?
Yeah, it's my practice has always been characterized by a bias that health is an expression of active mind, active body, active spirit. And we all need active expression in all those domains. This is my bias, but we all need expression in all those domains to have engaged health. And that's all very individual. That doesn't necessarily need to be prescriptive in how that rolls out. But if that isn't part, and particularly within childhood, there's the risk of not having a balanced expression of health, and some of those deficiencies can have lifelong impacts.
Yeah, completely. So let's say we find that those deficiencies created a scenario where there's weak bone, osteopenia, and we're doing REMS, and we get to this place where, okay, we've got a reading here that's unfavorable. What are some of the foundational pieces that you think? So we're transitioning now to actual programming and treatment per se for the patients in front of us. What are the foundational pieces you really turn to in that scenario?
Well, I mean, it starts with a foundational inventory. So we look at diet. I will have patients use a diet tracker of some form and actually get hard data. What are they taking in? And from a macro and a micro perspective, we'll look at what their movement practices are. So what are they engaged in from a physical health perspective? And that's the starting point. The cells that regulate bone metabolism are the osteocytes. So those are the mature cells in the bone, and they are primary mechanoreceptors. So the primary input into bones that directs bone metabolism is mechanical force. So and this is a phrase that we use, but bones have to bend, and it's intentionally a bit provocative, a term, because the general conception is that bones are stable, are static, and that's not the case. I mean, there's always turnover, there's resorption and absorption, and bones are 2/3 mineralized, 1/3 proteinaceous. And it's that allows for a little bit of bend in the bone. Obviously, that changes over time, but regardless, there's still always some degree of bend in the bone. And it's that bend that is the mechanical input into those osteocyte receptors that are directing bone metabolism. So, we can look at nutrition. We can look at macro and micronutrient levels and intake. We can look at what their supplementation is. We can look at their hormone picture, all those things. But if we don't have a mechanical input into those bones, all those things are secondary. So they're important and they're necessary. But it's kind of like, we can't just put cars on the road without traffic signals, without directing the flow of that. And so improving upon someone's like calcium intake and protein intake and nutrient phosphorus intake, all those things are putting more cars on the road. But if we don't have those traffic signals in place to direct where those vehicles are going, then we're not optimizing care for that individual. So that understanding of that basics of nutrient intake and movement practices are where we start, and then we build from there.
What do you think is the right amount of mechanical force? Is there a right amount, or is this total personalization, working the person up through an exercise routine?
Yeah, I think the simple answer that is some is better than none,
Okay.
and more is better than some. From an evidence-based perspective, we have the highest level of evidence based off the Liftmore trials. So the Liftmore trials were conducted in the late 2010s, a women's study and a men's study. Those looked at high intensity, high load exercises. The exercises that were looked at were back squats, deadlifts, overhead press, and then some impact loading. So that impact loading is heel drops of some form or another. And it's important to keep in note that these studies, those study participants were onboarded. So they were provided education in the movements themselves. They were supervised. And it's high loading. It is 85% of 1 rep max.
Nice.
And you're doing 5 sets of 5. That study looked at that doing twice a week. And the studies were done over 8 months. And that can be really quite frightening for people to think of doing 80 to 85% of a 1 rep max. And whenever I talk to rooms about this, I always pose that question to the group, and like, who thinks that they can do 80 to 85% of their 1 rep max? And almost universally, there's hesitation with that. Mm-hmm. But when you break that down and inform people that it's a relative statement, that your 1 rep max is for you, and that might be 20 pounds. So, you're working 80% of that, you're working at 16 pounds. Then it's a comparative relative load for your skeletal system. And then you want to build that up over time, but it is relevant to what your system is capable of, the force that it's capable of resisting and exerting, and then building that over time, recognizing that not everybody is going to be amenable to that type of lifting, to that heavy lifting. And that is why the idea of some is better than none and more is better than some. So, if there is not like availability of that type of training in the local area that of the person that we're working with, then there are some online self-paced, progressive, home-based exercises that have some evidence for them. And going back to what we were talking about earlier, we are talking about the motor bone unit. And so bone strength is critically relevant here, but the way that we move in the world, our proprioception, our physical literacy, strength, coordination, agility, all those things we can attain those without a high level of load. And all of those are really, really important, both from like a fall prevention perspective, and then also just mitigating some of the effects of a fall that may occur. So, the physical part of a bone health prescription is non-negotiable. It has to be manifested in one way or another. It has to be patient specific, and it has to be progressive. We have to meet that patient where they're at with what they are prepared to do with, a little bit of, maybe a little bit of gentle pushing. And then support them over that period.
Absolutely. And what do you think about vibration plates?
Well, so it's interesting. There's a bit of evidence for vibration plates. It's not really robust, but it's safe. It's approachable for many people. It's not quite. You could consider it passive, but the evidence is there, and what we see there is that vibration is sending a mechanical force through the entirety of that connective tissue, right? So when we're talking about those forces of tension on the compressive force of the bones, we're not just talking about the way that muscles and tendons exert tension, a force of tension on the bone. We're talking about the entirety of the fascia, the extracellular matrix, the entirety of the connective tissue on the system that increases tone and then positively exerts that force. And vibration is capable of doing that. And there is evidence to support that it is it's relatively low level. But honestly, all the things that we're talking about from an interventional perspective have low effect. Right. Less than 5% change of bone mineral density over the interval time.
Yeah, completely.
Yeah.
You started with nutrition and made some comments about tracking for macros and micros and looking at protein as a key macro, or at least you mentioned it, and calcium and phosphorus on the micro side. So that processing, you've got the diet recall, you've got your programming coming up. Is the programming specifically centered on those 3 items? Like, what is your programming approach like there?
Yes, that is the foundational part. So we get a lens on what they are currently intaking, and then make food-based prescriptions, suggestions to optimize that. And diet takes time to change, so there needs to be check-ins on that, depending on what results of that individual show, whether we're using the term osteopenia and osteoporosis, and it's important to note that both the academic and the clinical bone communities are wanting to move away from osteopenia as a term, and there's meaning in that. Osteoporosis or osteopenia has never been a diagnostic term, it's a descriptor. But what terming it osteoporosis, terming it osteopenia, terming it normal implies that there is discrete differences at different levels of the T-score. And so that osteopenia as a descriptor refers to bone mineral, a T-score of -1 to -2.5. Osteoporosis is less than -2.5. And we'll get these results back either from a DEXA or a REMS, and somebody will have a T-score on the lumbar spine of -0.09, and somebody else might have a T-score of -1.1, or we're monitoring that same person over time. We've assessed them in 2024, and they're -0.9, and then we assess them in 2025, and they're -0.1. Well, they're walking home in 2024. Oh, I've got a normal exam. They're walking home in 2025. Oh, now I have osteopenia. Mm-hmm. So that we want to be thinking about that as a continuum, as a spectrum, and not as these discrete categories, because there can be a false sense of positivity or a false sense of negativity depending on where those results lie. And again, the trend over time is what's important. So that's just an aside in terms of the osteopenia, but we feel that it's important because it's a shift in the way that we're thinking about this. We are thinking about this as a continuum. We are thinking about tracking this over time. We are thinking about trend over time.
Yeah.
So depending on where that individual's results might be, then we are integrating in supplemental levels of vitamin D, of vitamin K, of calcium, preferably supplemental calcium in an MCA, MCHC type of formulation.
Okay.
that metaphor that we were discussing before with like cars on the road and traffic signals, D and K are somewhat those traffic signals, right? So D is going to primarily help with the absorption of calcium. K is primarily going to help with the directing of calcium to bones and away from soft tissue. So it's those signals that we want in place to then shepherd the movement of the minerals, chiefly calcium, and while protecting soft tissue. So what we really don't want to be doing is throwing a big bolus of calcium in, like just a calcium salt orally. The body's not equipped to know what to do with this big intraintestinal bolus of calcium. And that's why we see the cardiovascular risk with large doses of calcium salts, is because that high load gets directed to soft tissue, and particularly the endothelium, to particularly vessels. So we want that symphony in place to ensure that the body has some degree of familiarity that when calcium is absorbed as a matrix with phosphorus and magnesium and protein and K and D, then it's being mobilized and then directed towards required tissue. Yeah.
Patients are really excited about D3K2, about taking combos of these.
Yeah.
And typically you see them as 120 micrograms of K2. Yeah. Can this be accomplished through leafy greens? Like, do we have to be using 120 micrograms of K2 orally? Is this like standard protocol for you, D3K2, or is it, if you eat kale, maybe just D? Like, how do you look at that? Because I don't know if you're measuring K2, are you?
Like from a diet tracking?
No, like from an actual lab test.
No, we don't.
They're not measuring K2. Yeah. So how do you approach it?
Yeah, I generally am suggesting the supplemental K2.
Yeah. Just for insurance purposes, just going there.
Yeah, exactly. But like all the fat-soluble vitamins, we're talking about a family of compounds. We're not talking about discrete entities. With K2, the more active forms, from a nutrient perspective, the more active forms of K on bone metabolism are going to be the forms of K that you find in more like fermented soy products, natto. And so it's pretty discrete in terms of the food sources that supply the active form of that. Mm-hmm. And it just, those aren't available to all palates and to all locations. And the leafy green forms of K, we don't have a means of understanding from a testing perspective how well those are being metabolized down to the active form. So for the relative safety and cost of supplemental K, I am generally still recommending that.
Love it. We do a lot of HRT in our practice, and I've been doing some reviews on the evidence for improving someone's T-score, because there is some evidence there for HRT.
Yeah, exactly.
Still less than 5%, I think. Right.
Yes.
So to your point about how good all of these interventions are.
Yeah.
Is there a place for HRT in your practice? Do you use it? Do you see benefits clinically?
Yes. Estrogen's primary role with respect to bone is slowing the rate of resorption, slowing the rate of loss. And in osteoporosis treatment, that there's a phrase that no loss is gain. And that is one of the things that we're looking at. We celebrate no loss when we're looking at over the time, because the expectation, even in a so-called healthy bone, is that there's going to be some degree of loss. So depending on what we're implementing, if we see status quo, that is a gain, that's a win. And the role of estrogen with respect to helping to slow that rate is evidence-based and important. And that is why we see this kind of cliff drop of menopause-associated change in bone mineral density. So again, we're looking at, on that prevention side and getting ahead of this, for screening individuals in that perimenopausal phase and have an understanding of where their bone health what their array of hormonal signs and symptoms, and then looking to see, is this someone that from a risk assessment perspective is a candidate for HRT, coupled with an understanding of, well, what is the baseline of their bone health? And we have another powerful indicated intervention and tool to support the patient, not obviously with respect to only their bone health, but with the entirety of their health.
Oh, I'm glad to hear it. I'm really glad to hear it. Yeah. I think it can be so valuable for people. People are scared of the conventional approaches. People are worried about bisphosphonates. People are worried about some of the newer medications, the injections that people get every 6 months or every year, however long they are now.
Yeah.
Tell me about some of the risks and benefits and how you decide for someone to go. I mean, we talked about the foundational principles, and now we have at least one more advanced therapy, like with HRT, for example, and MCHC calcium. How do we talk about, the side effects of conventional care and whether or not the person should actually make a decision to jump in?
That's a great question. So the side effects of conventional care are a little bit overblown. When we chisel down into the numbers, we see that with the bisphosphonates, which is the tier 1 medical intervention for osteoporosis, so that would be anyone with a T-score of minus 2.5 or less. That is an indication to initiate an anti-resorptive therapy. It doesn't mean that has to occur, but that is an indication for that. And with that class of medication, with the bisphosphonates, you're going to see absolute benefits per 1,000 patients over 3 to 4 years. With vertebral fractures, you're going to see 65 fewer cases. With non-vertebral fractures, you're going to see 53 fewer cases. Hip fractures, you're going to see 17 fewer cases. So, the number needed to treat for vertebral fractures is 9 to 20. The number for non-vertebral fractures is 17 to 43. So, we're not talking about a really significant positive benefit there, but it's present. When we look at the absolute risks of bisphosphonates, we're looking at the common ones are osteonecrosis of the jaw and atypical femoral fractures. And the atypical femoral fractures are going to account for about 1 per 1,000 per year after 5 years of use. So it is quite rare. It's out there, and we run into this with a high degree of frequency, that there is a high degree of hesitation or resistance to the initiation of these types of medications. And so it's our job as clinicians to educate and inform about what those risks are. More importantly, from our perspective, it is about understanding, okay, well, what is the mechanism of action of this drug? How is that impacting the bones itself? And then why might we be seeing these adverse effects? So for an atypical femoral fracture means that that femoral neck is going to have a shear type of fracture. So it's almost like a straight line across. And that is just not how bones typically fracture. Bones will typically fracture in a splintering way. And when you're looking at this only through the lens of that cortical bone, then we're missing out on that structural element of the bone, the trabecular bone. So we're talking about an anti-resorptive medication that has its primary benefit and primary effect at the cortical bone that is strengthening that by lowering the rate of resorption, but it really is not doing anything at the level of the trabecular bone. So the reason that an atypical fracture might happen there is that you have strength on the cortical, that outer lining of the bone, and then likely weakness at that structural. So you have a force going through there that causes this shearing fracture, like straight through, because that that structural part of the bone can't transmit that force. It goes back to the bias that is implicit in the way that we assess this. So we're using DEXA as a means of assessment, which tells us about that bone mineral density, which is that cortical bone, which is measured again in that 2-dimensional way. And then we're using medication that is predicated on the effect that it has on bone mineral density, on that cortical bone, without necessarily taking into consideration the entirety of the bone, structurally, histologically, and then from a systemic bone health perspective. And that is, it's often the nature of pharmaceutical therapy, is that it directs processes, and it can be at the exclusion of understanding the complexity of what's going on with metabolism and physiology of the region of interest that we're looking at. And so the idea of implementing initiating drug therapy, and that alone, in our opinion, that's just not great medicine, because it does not take into consideration the complexity of what's going on at the level of bone. However, if we go through this process with a patient where bisphosphonate is indicated, and we are talking about all the other things, so we're looking at macros and micros, we're looking at movement practices, we're looking at supplementation, we're looking at, as indicated, hormone therapy, and there's this arm of therapy, then we have a comprehensive approach to support this individual's health goals and their bone health. And that is the strength of a naturopathic model with respect to taking into consideration prevention, complexity, and individualized care.
Oh, totally. Super inspiring to hear all of that brought together as one. I just love it. So where do you think this is all going? I mean, obviously you're very bullish on REMS. I love it. I am too. I think it's I learned a ton from you today, just going over the details around it, and I'm really inspired. So thank you so much for that. So where do you think this is going? You think there's going to be a lot more prevention coming up in the future for us here in Canada?
Yeah, I've got my bias, I've got my conflict of interest. I'm involved in a company that provides this level of the assessment in the care. So we always have to own our bias. But I'm involved in this because my bias is such that there is no reason that we should not be screening for bone health.
Sure.
We use mammograms to screen for breast disease. We use FIT tests and colonoscopies to screen for colorectal disease. We use PSA and digital rectal exams to screen for prostate cancer. We have all these screening programs in place to catch and to change the course of the disease. And we have these strong numbers about the impact of osteoporosis at the individual, at the societal, and the public health level, and we don't screen for it. Mm. We diagnose this at the age of 70, and then we have a system that is empowered to implement drug therapy, which is one component of this highly complex state of bone health. And it's not good enough. And it's not aligned with largely the patients that we see who are interested in longevity, who are interested in avoiding frailty and being active, healthy, and engaged through the entirety of their health span. So, we have this tool, REMS, that is reliable, consistent, valid, that is portable, that has no radiation, and that can support and empower clinicians and patients in that process. And so, yeah, I'm bullish. I would love to see that there's a screening program in place to address bone health and osteoporosis.
Oh, that'd be so cool. And you'll be right there, man.
I will be right there.
Yeah, you'll be right there.
Yeah.
So thanks so much for your time. If we've got patients or clinicians watching who want to engage with your company or maybe get your test, where can they learn more about you?
So our website is bonehealthscan.ca, and we have there's quite a bit of information on there. So there's patient-directed information, there's clinician-directed information. We've developed a comprehensive osteoporosis guide that is directed towards both patients and clinicians. And then we've developed a comprehensive REMS interpretation guide, and that is directed towards clinicians themselves. So, we are a patient-facing organization, and we are very much engaged and believe strongly in the education and advocacy side of this. And we're doing a lot of work to try and develop the resources and the tools to support both patients and clinicians in this pathway. So the website, bonehealthscan.ca, is a repository of a lot of that information. And then there'll be a banner at the top of that links to our Jane booking site to show where there are upcoming scanning clinics.
Amazing, amazing, amazing. I'll check it out straight away. Thank you so much, Dr. Levins. I really enjoyed speaking with you, and I'm really excited about the direction that this is going for you and for people who live in our province in particular. So thanks so much for the great work that you do, and thanks for being on the show today.
I really appreciate the opportunity. Thanks a lot, Doc.
We'll talk again soon. Bye-bye.
Okay. Cheers. Bye.
Thanks for joining us for today's discussion. What about today's podcast resonated with you? Be sure to tag at Dr. David Duizer and at Get VitaminLab. If you're learning from and enjoying this podcast, please let us know by subscribing to our YouTube channel and follow the show on Spotify and Apple. And don't forget to leave us a review. It's the best way to support our podcast, and it helps others find us. To learn more or book a demo to explore what personalization could do for your practice, please go to www.getvitaminlab.com/personalized.